Clinical Judgment, Week 12. We have a client who is a 61-year-old male admitted with nausea, vomiting, and confusion. This client has nausea and vomiting times 2 days. Blood pressure is 143/86. Confusion, a blood glucose of 796. No regular form of exercise. The client is very thirsty and uses the bathroom frequently. The client has a temperature of 98.4, respiratory rate of 28, heart rate of 110, and bowel sounds active times 4 quadrants. What is pertinent in this client's case? What is relevant? And let's stick with just this client. I've chosen nausea, vomiting times 2 days. We know nausea and vomiting could be caused by a gastrointestinal virus or some type of underlying illness or electrolyte imbalance. That elevated blood pressure, elevated respiratory rate, and elevated heart rate all could be caused by fluid imbalances or hypoxia or decreased perfusion. Every one of those could lead to those elevations. With the respiratory rate, we could also be looking at respiratory infection or potential respiratory disease. But in this situation, I'm going to say it's more likely due to probably a disease process. Confusion. We know this could be our fluid imbalances or electrolyte imbalances, which with the nausea vomiting for 2 days could be a very likely situation. But why is he vomiting? Well, look at his blood glucose. Could also potentially be from infection or delirium or dementia, but I'm looking at the glucose. That elevated blood glucose is most likely DKA, diabetic ketoacidosis. No regular form of exercise means he probably has a sedentary lifestyle. He's not burning off glucose by requiring fuel for muscle use. And being very thirsty and using the bathroom frequently. Again, this is a symptom of diabetes mellitus. And we pair that with the elevated blood glucose. I'm going to say that is probably what is causing that issue. We know that hyperglycemia increases the osmolality of the blood, which increases the thirst. Potential complications. Well, nausea, vomiting, malnutrition, dehydration, electrolyte imbalances, and esophageal erosion. We have all of that acid coming up from the stomach, and the esophagus is not designed to handle that hydrochloric acid, and it can very easily erode those tissues. The elevated blood pressure, we know potential complications of that are going to be the CVA, aneurysm, decreased cardiac output. The elevated respiratory rate, we know, can cause respiratory alkalosis or respiratory failure. But in this case, he's probably breathing that fast to blow off acid because he is in diabetic ketoacidosis. That elevated heart rate, complications, heart failure, decreased cardiac output. He is definitely a safety risk because of the confusion. He's at risk for organ damage and death because of that really high blood glucose. No regular exercise can definitely lead to the obesity and osteoporosis immobility complications, and being very thirsty, using the bathroom often, the fluid and electrolyte imbalances are a real possibility. I think this client has DKA. So his elevated glucose is going to be the most important thing to deal with. We expect his blood sugars to be within normal limits. So is there anything that we are going to do at this point or avoid? We definitely need to avoid more glucose. So what would we do? We're going to monitor his vital signs and his blood sugars and monitor for potential complications. We may give some antiemetics. We're going to give insulin, but this case we're going to give it intravenously. And we need to give high volumes of IV fluids. We're going to give the IV fluids in addition to the IV insulin. And we need to provide diabetic education to include his diet, his medication, his exercise, potential complications, and sick day treatment. Remember, this is how a lot of diabetics are diagnosed, is they come in with a really high blood sugar, or people with DKA often will come in, they are known diabetics, they've been sick, they've been having nausea, vomiting, they have not taken their insulin. And because they've not been taking insulin, they haven't been taking their insulin because they have nausea and vomiting. They're not eating, so they don't feel like they need it, but they're not realizing that their blood sugar will still be elevated and insulin is still required. So what do we prioritize? In other words, what is potentially limb or life-threatening? We have to get that insulin going IV and give the IV fluids. So then we need to also monitor blood sugars and monitor for complications. Those are our priorities. Did our treatment work? Do we need to change anything? Do we need to tweak anything? Which client do we see first? Is it the client with a blood sugar of 189, a client who discontinued prednisolone, Is it the client who demonstrates a positive caustic sign? Is it the client with exophthalmos and an enlarged thyroid gland? Prednisolone is a steroid. If a client discontinues that without following the appropriate tapering orders, or they discontinue it abruptly, it can throw them into an Addisonian crisis. They can have life-threatening issues. We need to see that client first. However, number 3 is also urgent, but not emergent. We have a nurse who is assessing a client with Graves' disease and observes an abnormal protrusion of both eyeballs. How does the nurse document this assessment finding? What is this question asking? Well, this one's pretty simple. Basically, what is the protrusion of both eyeballs called? This is exophthalmos. The nurse would observe the client with untreated hyperglycemia for which condition? This question is asking what conditions are caused by untreated hyperglycemia. multitude of those we know. Is it respiratory acidosis, metabolic alkalosis, respiratory alkalosis, or metabolic acidosis? Well, we know that can lead to diabetic ketoacidosis. We know that that is a metabolic acidosis condition. We have a client with type 1 diabetes mellitus presenting to the emergency department with a blood sugar of 640 and reports being constantly thirsty and having to urinate all of the time. How does the nurse document this subjective finding? What is this question asking? Well, remember, subjective is what the client states. The client is constantly thirsty and having to urinate all the time. That's what the client stated. So, what is increased thirst and urination? Is it polydipsia and polyphagia? Is it polydipsia and polyuria? Is it polychoria and polyuria? Is it polyphagia and polyesthesia? The correct answer is number 2, polydipsia and polyuria. We have a client with a hypophysectomy, and we know that postoperatively they can experience transient diabetes insipidus. Which manifestation would alert the nurse to this problem? What is this question asking? Basically, what are the symptoms of DI? Is it urine output much greater than intake? A change in mental status indicating confusion? Laboratory results indicating hyponatremia? Or non-pitting edema of the lower extremities? We know diabetes insipidus is peeing out very large amounts of fluid. The correct answer is number 1. Next, we have a nurse who assesses a client in the emergency department and finds the following: constipation, fatigue with increased sleeping time, impaired memory, facial puffiness and weight gain. Which deficiency does the nurse recognize? What is this question asking? Basically, what are these symptoms indicative of? The correct answer is hypothyroidism, slow metabolism. Last question. Clients diagnosed with an anterior pituitary tumor can have symptoms of acromegaly. These symptoms are a result of overproduction of which hormone? What is this question asking? Basically, what hormone is related to acromegaly? ACTH, PRL, gonadotropins, or growth hormone? It is number 4, the growth hormone.